valuable lecture there. Like, there's so many different ways to change this based off the position you need. Like you said, I mean, what your mind is capable of achieving, that's your limits. So it's, I mean, you could go on for hours about this stuff. So this is just an example. So introduction, how do you treat calcaneus, whether it's provisional, definitive fixation, right? Or even you treat it provisional, you get it set up, you make it anatomic for the most part, except for the posterior facet, we'll talk about later. And then you come back and plate it, whether it's MIS or, you know, it's your full extensile lateral. Fantastic way to do it, makes everything so much easier. Case is dramatically easier, less complications with your soft tissue envelope. All right, so I am John Mansour Jr. I'm Director of Orthotrauma for the Houston Clinic at Ars Park Medical Center. So going through this just very quickly, and again, it's only 5 minutes, and I'm trying to see here so I can actually talk to you guys in a civilized manner. Generally, pathoanatomy about this, obviously the soft tissue envelope, that's pretty much what's going to dictate everything. As you can read about here, your problems with it. Again, the reason why, what are we trying to do? You got shortening, widening, obviously varus displacement of your tuberosities, and of course you get loss of Bowler's angle. So the point of this is you're waiting soft tissue recovery, right? So why not just wait soft tissue recovery and then go ahead and just plate it after? Why do you really need to X-fix it? People talk about this at least all the time now. I know proponents, at least when I was in residency fellowship, no one I saw X-fix anything for calcaneus. That was kind of like a laughed upon thing. Is why would you do that? That'd be stupid, because you basically putting your pins right there in the ball and you're going to get infection later, right? Or you're going to have pin site complications. So, you know, a whole argument for that can go on forever, but we'll talk about that in just a minute. So, you know, the reason why you get post-op wound complications for restoration of this, of your height, your length, you know, your displacement and all, you get acute retensioning of that soft tissue envelope. And depending on the contractibility of that, you know, if it's shortened, it's widened and all that too, then you pull it back out to length, you put extreme amount of stress upon that, and you cut your blood supply off, and you get soft tissue wound complications. All right, so what's your solution to this? You know, staged approach, just like you just saw there. Temporizing X-fix, been used all the time, right? I mean, it's like the gold standard care for P-lines, for bicondylar tibial plateaus, et cetera. So the way it works by is mitigation of your soft tissue complications. How do you do that? You improve your position, whether it's length, height, alignment, maintain optimal tension, promote edema resolution, and of course, it facilitates your future surgery. So low risk of pin site wounds, right? Like that's the whole thing. Do we have that problem actually happen? Well, I mean, look at P-lines, standard of care for that, right? No one would try to come take a blasted P-line in the middle of the night and try to fix that thing acutely, in the right mind at least, without worrying about your medical legal consequences. But again, standard care. Provisional X-fix, stage management, principal surgeries, as we just saw, and of course, definitive management for poor surgical candidates, non-compliant, comorbidities, et cetera. All right, so getting to this, the technique. Your frame is placed medially as so, right? Preserves your lateral soft tissues. Obviously, if you're going to be making your incision there, you don't want to disrupt that. So what do? You have your first medial midfoot pin is placed in your cuneiforms. Example here is 5 times 170 millimeter half pin. Medial middle lateral cuneiforms, your first step. Second one is placed with your medial tibial pin. Again, same one. Just want to make sure to stay above the incisor, about a centimeter, parallel to your plafond. And you know, another thing just to point out really quick is, if you use self-drilling, self-tapping pins on these with your half pins and all, that's going to decrease your stability drastically. So a technique, obviously, which most people don't really do anymore, is kind of your old AO technique of making sure you drill prior. Use your non-self-drilling, non-self-tapping ones. What if you can't get that? You don't have access to it? Cut the tip of the thing. Take a bolt cutter, cut the tip, there you go. Drill it, you got it. Example in general, even taking a 4 millimeter transcalcaneal pin from the sill set, it's got a nice sharp drill bit on it. Cut the thing in half, drill with that, place your pin in. All right, third, your medial calcaneal tuberosity pin. Again, 5 times 170 millimeter half pin. Again, low and posterior, obviously is your best bone. You got to be worried about your nerve in the vicinity if you go too medial. So perpendicular to your long axis, calcaneus, and parallel to the floor on the axial. This is very important. If you're correcting a calcaneus with that, what do you typically find your on the axial view? What do you find your posterior tube there? You know, so you got to make sure you're actually going parallel to that, because you're only going to be limited by how much correction you can obtain by the angle of your pin. I'll show you just right here. All right, so there you go. So you want to match that, and these are actually a bunch of these are taken from my cases, of course, that are going to be showing this, and hopefully some of these will actually go through the correct orientation here and correction. So as you can see, you're placed at an angle. Looks like you got a little bit wonky. It's not. You correct it. Now it's out to length. All right. So restoration of calcaneal height, length, longitudinal axis, multiple reduction movements in a stepwise fashion. The whole thing about this is you're basically placing distraction vectors depending on what your mind could come up with, and that's where SEAL just outshines anything else, because just like Circuit was saying, you're limited by what you're able to do with your compression and distraction by putting on, and a lot of the companies in the market now don't even have these things available. They're very difficult to find, plus you have to take them off and re-add them. It takes so much extra time, and then you get limited too if you're trying to do this after. Well, you got so many things in your way you can't even get to it. So this is something, as long as you're thinking about ahead of time and you're putting them on the correct way, it's amazing for compression and distraction. You can even do it in the office if need be. All right, so additional distraction vectors can be applied, again, as just by adding bars, right? So there's really no one way to do this. There's multiple ways I've done it, and still to this day, I pretty much start with these basic principles, and we'll add and modify as needed, okay? So here we go. Length height is initially reestablished first, right? How do you do that? So here's a small example. I want to use this red dot here, but I'm not really sure where it is. I don't want to mess this thing up. There we go. Fantastic. All right, so start with this first, putting it on. This is the old Synthes tensioner here device that I used prior to this. Basically establishing your bar here, length and height is adjusted. My thing really to go to now is establishing it here and building off of it this way. So pin bar clamp application. Tibial to cuneiform pin is applied. Second, you establish your bar apparatuses. Again, this makes a T. Now you brought this out to correct length, right? Basically the thing you have to worry about is when you do this, you're also going to get translation lateral to medial, right? So how do you correct that at the same time? So as you place the valgate moment with a calc pin to your T handle, you will get that translational deformity. What I've found is taking your T handle chucks, and this is pretty much with anything, whether you're trying to control your sagittal or coronal plane. Attach your T handle chucks here, and you can use that perfectly. And then you can also, pretty much attach your bar to bars or pin to bars, whatever associated with it. So build off of it, right? So now you got a nice little strut here, you got a nice strut there. Now you take this and you open it up, and you pretty much pulled it right back. Obviously you have to loosen this pin prior. All right, so here's where you're taking your height and length fine tune, and that's really your final step. And now it corrects everything. So here's just an example of what I used to do prior. And you come back and now you got this, right? So what does this look like? All right, 24-year-old female, stats with MVC rollover. She comes in, she's got this fracture here. As we can see, she's obviously in significant displacement. And you can tell here, again, I've cut my pins right there, okay? Now place here, I'm bringing it out to length. Restoration of height, valgus. There we go, final product here. And now again, this is tough concept here because of obviously I do have a lot of stuff in the way, right? So this is blocking me, can't really see much. But as you can tell here, everything's lined up pretty well anatomically, or at least everybody says so. It's based off of interop fluoro. Now the one thing you cannot correct is your posterior facet for obvious reasons. That's the one thing you're not gonna be able to do perfectly. Now yes, you can place pins from that. That's pretty much a separate lecture, but you can place pin off of this to it, bring it up, but again, that's making sure if you're going to be doing that you're treating it definitively. So this is just fine tuning, as you can see there, and then of course here's your finals. So is it truly anatomic? Well, I had a video of this loaded up, which was taking way too much memory, especially with centricity system, which is like 1970s cutting edge technology. So I just went ahead and took some slides here for it, so you can see everything's pretty well anatomically restored, except again for your posterior facet. All right, so here's different images. Yeah, it's horrible looking, right? Awful technology for that. All right, so what I decided to do, go back in for just a sinus tarsi approach. Very easily done. Cases under an hour, It's pretty impressive for a calc like that to be able to do it, and then there you go. It's all done. So it literally just, you walk in, You can still, you have your X-fix on immediately, set the patient down in the lateral position, make your incision, everything's done just like that, and you barely have to do any work at all.